Welcome, everybody. Last week, I explained that we were fortunate enough last year to have appointed 4 academic clinical lecturers to Newcastle. And Iram Haq was the first one who talked on cystic fibrosis. And I'm delighted to be able to welcome today Aisling Flinn, who's actually working with us in immunology and transplant. And she's going to explain something about her PhD and her thoughts for the future. Can I just remind you all to mute if you haven't already? And Aisling, thank you. We look forward to your talk.
Okay. All right, thank you. Good afternoon, everyone. So as Andy said, my name is Aisling Flinn and I'm an ACL in Pediatric Immunology and Transplant. And I'm going to talk today about understanding how tolerance develops in stem cell transplantation, or teaching T cells to be tolerant. So I'm going to talk a little bit about what immune tolerance is in normal homeostasis and the setting of stem cell transplant. I'm going to talk a little bit about what the manifestations are when tolerance fails to develop in stem cell transplant patients, and then a little bit about my own research plans into tolerance for the future. So immune tolerance describes a state of unresponsiveness of the immune system towards substances or antigens. So this could be self-antigen, or it may be environmental or food antigen. And this is an essential part of our normal immune system. So immune tolerance mechanisms protect us against immune responses that are directed against ourselves, which is when autoimmunity occurs, and also protects us against harmful excessive inflammation. So, for example, in the case of infection, where a degree of inflammation is important, there are immune mechanisms in place to rein in that inflammation to prevent it from being uncontrolled. So immune tolerance can be described as central or peripheral. So if we focus on central tolerance to start with, this describes the immune mechanisms that take place within the thymus gland, which is the lymphoid organ where our T cells develop. So for the normal process of T cell development, stem cells are recruited from the bone marrow and they enter the thymus gland. And then the developing T cells undergo a series of maturation steps. And part of this involves the removal of developing T cells that react with self-antigen. So these autoreactive T cells, which have the potential to cause autoimmunity, are deleted. And the result of this is that the new T cells that are exported from the thymus into the circulation are called naive T cells or new T cells, which are self-tolerant. As well as central tolerance, there are also mechanisms of tolerance outside the thymus called peripheral tolerance. And these are a bit more diverse, but a key component of peripheral tolerance includes regulatory T cells, which is represented here with some of the intracellular and surface markers that it expresses. So achieving immune tolerance is one of the key goals that we strive for after stem cell transplantation. And what we mean in the context of transplant is an immune system that is unresponsive to the graft, but is still able to mount immune responses against pathogens. However, when tolerance fails, this can manifest as the patient T cells attacking the donor graft, which describes rejection, or the donor T cells attacking the patient, which occurs in acute graft versus host disease, which is what we more commonly see in stem cell transplantation. And this manifests as harmful inflammation that can be life-threatening, affecting predominantly the skin, the gut, and the liver. And so when these types of scenarios occur, we treat them by using immunosuppressive therapies that dampen down the attacking T cells. So usually we use corticosteroids to start treating these complications. However, although steroids are very effective at reducing inflammation and dampening down attacking T cells, they also don't actually help us achieve our goal of immune tolerance, and they have a host of other adverse effects. And so this introduces this balance that we don't often see in our transplant patients, where we are using non-specific immunosuppressive therapies like steroids to dampen down the T cells that cause graft versus host disease. But on the flip side, these therapies also increase the risk of infection, relapse, and secondary malignancy as well as having a negative effect on immune reconstitution, and also, as we all know, have a host of other drug-related side effects, such as hypertension. So I was going to use two cases to try and illustrate this balance that we often see in our stem cell transplant patients. So this is a 7-month-old boy who has a diagnosis of severe combined immune deficiency, who was diagnosed relatively late and before transplant was positive for rotavirus and also for CMV. So he underwent stem cell transplant and engrafted after 18 days, but 6 weeks after transplant, he develops a rash. And so this is a rash that we see that's typical of quite severe GVHD. So it's a widespread erythematous maculopapular rash that often is quite pronounced on the palms and the soles. And in severe cases, like you can see here, it can blister, it can cause desquamation, and it can also lead to hypo and hyperpigmentation. So in this little boy, he had a widespread rash that involved more than 50% of his body surface area and was diagnosed with stage 3 acute skin GVHD. So he was started on 2 milligrams per kilogram of IV methylprednisolone and continued on cyclosporin, which is what we use for GVHD prophylaxis. The rash was slow to respond, so infliximab was added and the rash then gradually improved. However, in parallel with this, because of the immunosuppression that he was on, the CMV levels in the blood started to rise. And so to try and counteract that, the steroids were weaned, but the rash then started to flare. He subsequently developed increased work of breathing and an oxygen requirement, was later transferred to PICU, and died of respiratory failure, which was thought to be CMV pneumonitis. So this represents the balance that we don't uncommonly encounter with our transplant patients, where we're using therapies to dampen down the T cells causing acute GVHD. But at the same time, we're subjecting them to an increased risk of infection, particularly viral reactivations, which is a major cause of mortality for these patients. So this demonstrates a deficiency or a lack of tolerance in this patient, with the donor T cells from the graft attacking the patient tissues. And a big question is, why does this happen? The short answer to that question is that we don't fully understand. But a key part in understanding that is knowing how T cells recover after transplant. So as you can see in this diagram here, there are 2 pathways by which T cells recover after stem cell transplantation. So if you just focus on the top part first, the first pathway by which the T cells recover is called the thymic independent pathway. And this involves the expansion of donor T cells or patient T cells that have survived conditioning. They expand in the host in the peripheral blood and are important because they do provide some protection against infection and are also important in the graft versus leukemic effect for patients. However, the downside is that they're relatively limited in numbers, they have limited diversity, and they're not permanent, as well as causing an acute graft versus host disease. So what we're really trying to achieve is T cell recovery by what's called the thymic dependent pathway, which basically means the production of new T cells within the thymus gland, like I outlined in the first slide. So this involves stem cells from the donor graft traveling to the thymus and then undergoing those steps of maturation and education that I described previously, resulting in the export of new T cells, which are self-tolerant because they're educated in the patient's thymus. So like I said, these new T cells are tolerant of self, they're hugely diverse, which means they're able to interact with a huge number of different antigens, and they're long-lasting. But the downside of the thymic dependent pathway is that it's relatively slow, and it takes about 4 months for us to begin to see these new naive T cells in the patient's circulation. So then the second case is a 4-year-old boy with relapsed AML who undergoes stem cell transplant. And 3 weeks later, he develops stage 3 skin acute GVHD, similar to our first case. He was also started on IV methylpred, infliximab, and continued on cyclosporin. But because of an incomplete response of the rash, he was started on a therapy called extracorporeal photopheresis, or ECP. So for those of you who aren't familiar with ECP, ECP is now the second-line therapy for acute GVHD, and it is a procedure that involves the patient being connected to a machine. Whole blood is removed from the patient, and the red blood cells are immediately returned, And the mononuclear cells of the patient are then treated with a combination of a chemical called 8-methoxysorolin and UVA light. And these treated mononuclear cells, which include the T cells, are returned to the patient. So ECP is said to be antigen specific, which means that it targets the T cells causing GVHD, but it spares other T cells. And also is said to promote immune tolerance rather than causing immune suppression. So these two factors mean that patients who are treated with ECP are not subjected to further increased risk of infection or relapse, and has the benefit of allowing us to wean their immune suppression, as well as having a relatively good response rate of about 70%. So for this little boy, his skin rash started to improve, his infliximab was stopped, his steroids were weaned and eventually stopped. And then this is what we see in terms of his thymic-dependent T cell recovery. So this is one of the patients that I followed as part of my PhD, which looked at thymic-dependent T cell recovery with ECP progression. So if we look at graph A here on the left, this demonstrates that with ECP progression, we see an increase in the number of naive T cells and the frequency of naive T cells. In graph B, we see a rise in the number of TREX, which are just another measure of thymic production of new T cells. And in graph C, we see a fall in the serum IL-7 levels in parallel with the increase in naive T cells. So serum IL-7 is a cytokine that's predominantly produced by thymic epithelial cells in response to low T cell numbers. So we can see that when the T cell numbers are low, the serum IL-7 levels are high, and then it falls as the naive T cells recover. So this is a nice example of the patient demonstrating T cell recovery that coincides with reduced GVHD activity and weaning of his immune suppression. And these new T cells, like I said, are educated in his thymus and produce long-lasting tolerance of self. So how does ECP promote tolerance? So this is what an ECP machine looks like here. And from what we understand, the exposure of the mononuclear cells to the combination of 8-methoxysorolin and UVA light results in apoptosis, with the activated T cells being preferentially affected. And then the activated T cell apoptotic antigen is then taken up by dendritic cells. And then the dendritic cells are a key player in then mediating mechanisms of increased peripheral tolerance by a range of different pathways. So what we see is that the dendritic cells take on a tolerogenic phenotype, which means that when they interact with their corresponding T cell, it results in T cell anergy as opposed to T cell stimulation. We also observe an increase in plasmacytoid dendritic cells, which are a subset of DCs that are said to induce tolerance. We also observe increased Tregs and changes in cytokine profiles. And so although there is still quite a lot of work to be done to really understand which pathways are predominant in ECP, what we generally see is an upregulation of peripheral immune tolerance that's specific to the T cells causing acute GVHD. And so just to touch on some of the results from my PhD, where I followed children who had severe acute GVHD that required ECP treatment. As I demonstrated in case 2, what we found was that patients who responded to ECP had quantitative and qualitative thymic recovery of new T cells, and therefore also had restoration of their central tolerance. And one of the interesting findings was that when we compared the new T cell production in ECP patients, it appeared to be faster in that group compared to patients with GVHD who were just treated with corticosteroids. Which are represented here by the middle bar. And the bar on the far left are patients with no acute GVHD at all. And so while that's a small number of patients and needs to be interpreted with caution, it does demonstrate the negative impact that both GVHD and steroids have on T cell recovery after transplant. And then some further work demonstrated some changes in dendritic cells and regulatory T cells that suggested upregulation of peripheral tolerance in the patients who responded to ECP. And one of the other interesting findings was that some of these changes in peripheral tolerance appeared to downregulate in parallel with the return of thymic function and central tolerance. And the reason that's interesting is that it suggests that potentially there is a dynamic relationship between central and peripheral tolerance mechanisms. So in these patients, when their thymic function and their central tolerance is absent, it appears that their peripheral tolerance is increased. So it seems that potentially these two parts of the immune system are able to talk to each other in some way. So this leads on to some of my current research interests and plans. So leading on from those results, what I'm interested in is trying to understand in patients, all stem cell transplant patients, before their thymic function returns after transplant, are there immune mechanisms in place that actively promote tolerance between the donor and the patient? And this is interesting because not all patients develop acute GVHD. And although we have various strategies in place, like HLA matching and graft manipulation to try and reduce the risk of GVHD, graft versus host disease does still occur, and in patients where you might expect it to occur because of a HLA mismatch, it doesn't always occur, which suggests that there may be mechanisms in place that are actively promoting tolerance between the donor and the patient. And are there mechanisms that are similar to what was observed in the ECP patients? And then importantly, if there are immune mechanisms that actively promote tolerance, what happens when they fail? So what deviation provides a permissive environment for acute GVHD to develop in the patient? And then thirdly, as T-cell recovery is so important to restore central tolerance, how can we promote it? How can we make it occur faster and thereby protecting the patient from infection and graft versus host disease? And so some of my initial research plans are to look at these patients in that early transplant period, so between the first month and the fourth month when there's no thymic function present and therefore no central tolerance, with the hypothesis that being that during this time period, there's an upregulation of peripheral tolerance mechanisms. And so the plan is to initially focus on regulatory T cells, as we know that they are an integral player in peripheral tolerance, looking at their frequency and their number, their suppressive function, their phenotype, so what proteins they express on their surface and intracellularly, and also their transcriptome, so looking at what genes they're expressing. And the plan is to look at transplant patients who have no acute GVHD and therefore who I would call have active tolerance, and comparing those with transplant patients who have acute GVHD and therefore who I would label as having failed tolerance. And then looking at these changes longitudinally to see if there is a difference with return of central tolerance with thymic function. So this is potentially important because it could help us to understand why acute graft versus host disease develops in some patients. It has the potential to develop biomarkers to identify patients who are at risk of graft versus host disease. And this can help with our ultimate aim of providing an individualized approach to managing these patients. In addition, it could potentially lead to the development of tolerance-inducing therapies, so improving our use of and our understanding of extracorporeal photopheresis, as well as developing newer therapies. And importantly, reduce our need for non-specific immunosuppression, which has those disadvantages that I outlined earlier. And because stem cell transplant is a really unique opportunity to look at the immune system following its reset, information of tolerance in this area can also be transferable to other fields, such as solid organ transplant and in autoimmunity. And so that's the end of my presentation, and I'm happy to take anyone's questions.
Brilliant. Thank you very much, Aisling. I realise I'm biased here, but really interesting talk. So this is open to question. Please feel free. Yeah, Jeff?
It's really interesting and really well presented, I thought. Again, probably coming from a slightly biased point of view of having some background in this, but how do we try to maintain the maximum graft versus leukemia effect alongside your inducing tolerance and reducing GVHD?
Well, that's the $1 million question, really, isn't it? So if we can, that's what we're trying to achieve. We're trying to achieve tolerance that's specific to T cells that will cause graft versus host disease, but sparing those T cells that are important for not just GVL, but also for infection. So I don't have the answer to that question, but that is what, I would like to see. I suppose what would be interesting to see is, by studying the immune system and particularly Tregs over the course of that early transplant period, are there changes that might, that in patients who have relapse early on, do they have higher tolerance, for example?
I mean, it's interesting, isn't it, that ECP actually originally was started when it was initially introduced was not to treat GVHD in an immunosuppressive way, but was to treat peripheral T-cell lymphoma, cutaneous T-cell lymphoma, in a sort of turning on aggressive way rather than a damping down immunosuppressive way. So there's clearly something about how ECP works that allows both of those things to happen, and quite how that is, I mean, who knows?
I also enjoyed the very clear explanation of how ECP works. That's a beautiful work of fiction, so thank you. That made my day.
Oh, you're welcome.
I still put it down to pixies and fairy dust myself.
Well, the truth is we don't understand how it works fully, and of all of those mechanisms that I listed, it's not clear whether there's one predominant mechanism or if it's a combination of multiple mechanisms. So there's still a lot of work to be done.
But very important and interesting work, so thanks.
Yeah.
Any other questions? So I have a question. I mean, you touched on it very briefly at the end, and clearly your focus here is on stem cell transplantation in PID and in malignancy. But actually, this concept of tolerance and maybe even the use of something like ECP has a much wider application. Do you see that's something that we could be doing here?
Yeah, absolutely. I mean, there is evidence of ECP being used in solid organ transplantation, and I know that there's, hope and scope to expand the use of ECP, for example, in lung transplant and potentially in heart transplantation. And I think there's a lot that we can learn if we are able to look at the immune system in those patients as well. And then, absolutely, I mean, potentially it has use in other types of solid organ transplantation and also in autoimmunity.
Okay, Yincent.
Yeah, I'm really interested in the ECP. We may give a go for our next transplant patient.
Yeah, no problem.
I'll put you in touch with Julie Guest and you can negotiate that one.
Excellent. Good. Do we have any other questions? I mean, I think it's a really interesting topic, this, that it's clearly kind of cross-cutting. And I think one of the problems is that we all think of our own little silos, but actually, and I think Iram gave a similar sort of talk last week, where some of the concepts that are there are available for more than one specialty within paediatrics. And that's actually like one of the beauties of this forum, where we get to hear things that maybe are outside our own field, but actually have a resonance.
Yes, absolutely. I definitely agree with that.
Yincent or Frederick, do you have any questions? Or anybody else?
You actually hit the hammer and nail there. Is that the idea of these webinars is so that people can share what they're doing and then try to it's interfaces where the innovations are coming from.
Yeah, absolutely.
Thank you for coming to present. Yeah, so next week there is a share day on global health, and it's a free share day. It's going to be on Zoom, so there's no Wednesday lunchtime talk as such. However, we'll send the program around to everyone, and if anyone wants to join, you can dip in and dip out of it. So Steve has come up with a really nice list of speakers, and I'm sure it'll be very interesting, especially in these COVID times. So thank you very much, Ashley.
Cool, no problem. Thank you.